So even before the election, I talked to Jimmy about a president's commission similar to the one that we had had in Georgia when he was governor. And one of his first official acts, as Dr. Wetterberg said, less than a month after he was inaugurated as president, he created the President's Commission on Mental Health and named me as honorary chairperson. I had to be honorary chairperson because it's against the law in our country for the wife of a president to be a chairman. I don't know why, but it was all right to be honorary chairperson, but not chairman. We had 20 members on the commission, and we were given a one-year mandate to identify how America's mentally ill was served or underserved, and then to identify, one, the projected needs for dealing with emotional distress during the next 25 years, two, the ways the President, Congress, and the federal government might most efficiently support the treatment of the underserved, three, methods for coordinating a unified approach to all mental health and support services, four, the types of research the federal government should support to further the prevention and treatment of mental illness and mental retardation, five, the roles educational systems, voluntary agencies, and other institutions could perform to help minimize emotional disturbances, and six, to the extent possible, the cost of mental health programs, how the money should be spent, and how financing should be divided among federal, state, and local governments and the private and philanthropic sectors. As you can see, our task was not simple. It was exceedingly complex, but we undertook it with great enthusiasm. And these books you see here are the report. And we had many, many people who worked to make that report possible. We didn't have very much money. My husband was president, but he only allocated a small amount of funds. But we went to people in the whole country and got help anywhere we went. It was really a wonderful experience. Not since the days of John F. Kennedy had there been a comprehensive study done of the mental health care and the mental health needs in our country. During that time, the federal government had greatly expanded its role in assuring that the needs of the mentally ill would be addressed. Prior to this, the states had had total responsibility. But this movement to improve care at the national level had begun with the onset of World War II, when medical screening of those called for military service revealed a startlingly high level of rejection for psychiatric disability. The striking prevalence of serious mental or emotional illness raised concern about the state of knowledge of the causes of mental illness. And so the next 2 decades then, when interest was aroused, and we had in the White House a president who was concerned about mental illness, the 60s, beginning in the 60s, the 60s and the 70s were exciting years in the mental health field. Investments in research around the world bore fruit with the development of more effective drugs for the treatment of the mentally ill, new behavioral therapies, and greater insights into how the brain functions. During these years, there developed in America a strong national consensus that the care for the mentally ill could indeed be improved, that it could be provided in decent, community-based settings by highly skilled professionals, and significantly, that many, many seriously mentally ill individuals could live and function well outside institutions, provided follow-up care and supportive services were available to them. Much progress was made in the care that was provided in our country during these 2 decades. Yet our study, the study that we began in 1977, convinced the members of the President's Commission that a substantial number of Americans still did not have access to mental health care of high quality and at reasonable cost. For many, this was because of where they lived, as I said earlier, in rural areas especially. For others, it was because of who they were, their race or age or sex. Children were neglected to a large extent, the elderly. For still others, it was because of their particular disability or economic circumstance. Our commission presented to the President recommendations that would make possible adequate care for all persons that needed help. We worked hours and hours and hours. I studied in detail, not every report, because we had 34 committees with more than 450 people serving on those committees. who sent us volumes of information and papers. And I'll have to admit that I didn't read all of it, but I did go to all of the hearings when they reported to the committee and read the material, the summary material, and so that I would have an understanding of it. Legislation was drawn up to encompass the recommendations that we made to the President. I worked with the Cabinet Secretaries in drawing up this legislation. And then once the legislation was presented to Congress, I went to the Capitol and appeared before the congressional committees to lobby for the legislation. And in 1980, the Mental Health Systems Act became law. Unfortunately, with the change of administrations, all of the things that we had envisioned have not come to pass. In fact, some of the legislation, to my regret, has been repealed, but the study is still there to serve as a guide, and I am confident that over a period of time it will all become law and it will all be implemented. The mental health system of America is still in a state of evolution. It combines public and private personnel, facilities and financing without clearly established lines of responsibility and accountability. While there is much that is good, there is much that needs improvement. This is especially true of people with chronic mental illness. That was one of our main concerns in our report, was a good program for the chronically mentally ill. It's true of many children and adolescents and older Americans, and of the poor, many of whom are members of racial minorities. The plight of the chronically mentally ill illustrates the difficulties that still exist. These people with severe mental disabilities, which often persist throughout their lives, have very special needs, but their needs are not always identical. Some require a sheltered environment, some need a variety of supporting social services, while some need only periodic assistance. There are still others who achieve a high level of independent functioning. As a group, they are the individuals who in earlier times would have been the residents in the large state mental institutions. And they are the ones that were supposed to benefit the most from the shift to the community center. But in many instances, the chronically mentally ill were released from the hospitals to go to the communities before adequate services were provided in the communities. And the deinstitutionalization of the chronically mentally ill brought with it its own problems, as in city after city, thousands of individuals led lives of cyclical despair, in and out of institutions, sporadic medical care, inadequate living arrangements, wandering from temporary shelter from one to another. And so what our commission found was in many ways a perplexing paradox. Millions of Americans had access to better mental health care than ever before, yet hundreds of thousands with the most severe, debilitating types of mental illness were leading lives of desperation.